So good morning, dear friends, postgraduate students and co-faculty. A very nice morning. So we have already started discussing the ECG in a more clinical sense and understanding it. So we had the first session last time. This session we are going to focus on two issues. One is the rate determination. The other is the axis determination. So this is the objective of today's session. One, rate determination; two, axis determination. So let me now share my presentation with you, and I'm closing this. And okay, so of course, very warm welcome to everyone, and of course, we are all ready to take on the workshop. So again, a clinical approach is important for us for ECG interpretation. Needless to say, this is available on our website www.drsarma.in. Again, pronouns to the great teacher, Alan Lindsay. And of course, we are going to use some of his ECGs and his students' website. Alan Lindsay's website for ECG learning is hosted by Dr. Young, Professor Young, who is an emeritus professor of medicine in Utah University. So just to recapitulate what we learned, so we have what is called the wave patterns of the ECG, the P wave, the PR interval, the QRS complex, the QRS interval, the ST segment, the T wave, the U wave, the QT interval, and the RR interval. All of you keep your microphones muted. So these are the wave patterns. Just I will recall those things for you. So the one that we see has one is the P wave due to the atrial activation. And from the beginning of the P wave to the beginning of the QRS is the PR interval, which includes the P wave as well as the PR segment, and then the little Q wave, which is a normal physiological Q wave, and the QRS complex, the J point, the ST segment baseline, which is not elevated or depressed normally, and there is a T wave here and a U wave. And the 6 is the QRS interval. This is normally very narrow QRS, and we'll see. This is the QT interval. We learned that QT interval is 0.4 seconds. Cardiac cycle is 0.8 seconds. So half of the cardiac cycle or half of the RR interval should be the QT interval, and it is rate dependent. So we need to adjust it. So correct lead placement and good contact and proper earth connections we know. Deep inspiration in L2, L3 and AVF we do. Compare serial ECGs. Relate the changes to age, sex and clinical history. Consider the comorbidities, particularly electrolyte disturbances. Keep a photocopy and interpret systematically to avoid errors. We also learned there are 12 cameras recording the electrical activity, and 6 of them are limb leads and 6 of them are the chest leads. Among the 6, 3 are bipolar leads, L1 between LA and RA, L2 between left foot and RA, L3 is again left foot and LA. Simply speaking, L1 is the horizontal lead like this between right arm and left arm being the positive lead. Likewise, L2 and L3 foot is the positive lead. In ECG, man has got only one foot, the left foot. Connecting between the left foot and right arm is lead 2. Left foot and left arm is the lead 3. Now, there are unipolar leads, which we also know. AVR from the right arm, which is positive. AVL is the left-sided lead, which is left arm positive. AVF is the foot positive. So much so we have in the limb leads, we have 2 lateral cameras, the L1 and the AVL, and then 3 inferior cameras, AVF, L2 and L3. And we have the anterior posterior cameras which are on the chest, which are called the chest leads. So the chest lead placement, V1 is the 4th intercostal space on the right side of the sternum. V2 is exactly same position on the left side. V4 is at the apex beat or 5th intercostal space mid-clavicular line. And between 2 and 3 is 2 and 4 is the 3. Fifth lead is in the anterior axillary line, same space, fifth space. And sixth is in the anterior mid axillary line, so in the same space. Why it is so important? It is important to keep the leads correctly in the respective places. One, to compare different ECGs of the same patient, and also the internationally, whatever you call V1, I should also be knowing what is V1. So like what is V6 should be V6 everywhere for the uniformity of the thing. Likewise, the limb lead placement also is exactly what we have described. So that is V1, that is V2, that is the between 2 and 3, and V4 is at the apex, and V5 anterior axillary line fifth space, V6 is mid axillary line fifth space. This we know. So that's what exactly is described here, V1 to V6, what we have just now discussed. These are the precordial cameras. What does they record? They record the anterior posterior activity. So we have the septal leads, V1 and V2 are called the septal leads, V3 and V4 are the anterior leads, V5, V6 are the lateral leads. Now, how many lateral cameras we have? Something is happening on the lateral surface of the heart or the left side of the heart. So we know in the EL1, we know in the AVL, we also know in V5, V6. Something is happening in the septum area, we get it in V1, V2. In the anterior surface of the heart, V4, V3 and V4. Something is happening on the diaphragmatic surface or the inferior surface of the heart, we will be seeing in the L2, L3 and AVF. These are the inferior cameras. Only one thing is left, which is the AVR. AVR is called the cavitatory lead, which is a reference lead and which is normally not used. Normally, AVR deflection is always negative in the ECG. Now we go for a rate determination. Very simple approach I'm going to tell. And of course, you can exactly also calculate from the ECG. That's not a very difficult thing. So the rate determination simple approach will be. So let's continue from where we left, and let me share the presentation again. So you can see that we are going to have two important things to do, the rate determination and the axis determination. I'm going to show you a very simple approach for rate determination. Okay. So we earlier know from the ECG paper that there are thicker lines and thinner lines. We know that the distance between two thicker lines, this is a thick line and this is another thick line, between them is 0.2 seconds, right? 0.2 seconds, and small square is 0.04 seconds. A small square, each small square is 0.04 and the total is 0.2 seconds. This is already told to you. Now, just divide 60 seconds is 1 minute, isn't it? We wanted to know the rate. 60 seconds divided by 0.2 will be how much? 60 divided by 0.2 will be 300. So if the first complex falls here and the next complex falls after one big square, the rate will be 300. You understand? Now, if the first complex falls and the next QRS is here, that means 0.4 seconds it took for the cardiac cycle. 0.2 plus 0.2. So 360 divided by 0.4 will be 150. So this line we will name it as 150 line. So let us go to the third line. Suppose the first complex falls here and the next QRS occurs here. So it took around 3 big squares for the next RR interval to come, for the next wave to come, and the RR interval is 3 big squares. 3 big squares is 0.6. So 60 seconds divided by 0.6 is equal to 100. That is the line of the 100. So 300, 150, 100. Let us look here. There are 4 squares it took. 4 squares means the first complex fell here and the next complex, let us say QRS has occurred. The RR interval is 4 big squares. 4 big squares is equal to 0.8. So 4 big, each is 0.2. 4 big squares is 0.8. 60 seconds is 1 minute. 60 divided by 0.8 will be 75. Okay. Let us say the QRS has occurred here and the next QRS occurred here. It is 5 big squares, which is equivalent to 1 second. 60 seconds is 1 minute. 60 by 1 minute will be 60. Like that, this will be 50, this will be 43, and this will be 37. So we will name the sort of lines like this: 300, 150, 100, 75, 60, 50, 43, 70. Just to memorize them. Why I did not go beyond this? We are not interested to have anybody who is less than 37 because it is incompatible with survival below that and they require a pacemaker. Likewise, any atrial or ventricular rate which is more than 300 is not sustainable. So our interest is basically somewhere from here to here. So in such a case, please label all your lines. So if the first QRS occurs here, and let us say the next QRS occurs here, the rate is 300. Is it audible, sir?
Yes, sir, audible.
Sir, please mute your mic, sir.
Audible, sir, audible.
Audible means fine. Please, whenever the same instructions are, whenever it is not audible, disconnect and reconnect. That is the only instruction. Okay. So this line is 300 line, this line is 150, this line is 100, 75, 60, 50. I explained you why they are. So for example, the 60 line I am taking here. This is taking how much time the RR interval? 1, 2, 3, 4, 5. 5 into 0.2, each big square is 0.2. 5 into 0.2 is 1 second. 60 seconds is 1 minute. 60 divided by 1 second is equal to 60. So that is how we have labeled the lines. Life becomes very easier. You will be able to tell the rate within a fraction of a second without doing any calculation. Let us go further. So immediate 1 second, immediate box means 0.2 seconds. 0.2 seconds, 60 divided by 0.2 seconds is 300. After 2 boxes, it has come, that is on the second line, it is 0.4, so 150. The third line is 3 boxes is 0.6, that is 100. The fourth line is 4 boxes, which is 0.8. 60 is the constant always because this is the number of seconds in a minute. So that will be 75. And anything 5 boxes exactly is 5 boxes make 0.2 into 5 is 1 second. 60 seconds divided by 1 is 60. And like that, this will be 50. 7 boxes is 1.4. 60 dividing 1.4 dividing 60 is 43. Likewise, 1.6 dividing 60 is 37. So why I marked these things as white? Because that is the zone in which you are interested. As a clinician, you tell me whether will you be interested to know whether the heart rate is 82 or 86 or 75. All the same, isn't it? I would like to know whether the patient is brady or tachy. Sometimes for prognostic purpose, you can just keep the check on the pulse rate. But in general, for a clinician, the interest is it normal heart rate or is it tachycardia or is it bradycardia? Okay, like that we have to understand the rate calculation. Now let us go into the real life examples. So brady, tachy and normal. Anything less than 60 is bradycardia. Anything more than 100 is tachycardia, which is our patient. Now, look at this ECG and tell me what is the heart rate. How do I know that? I will take the one which is falling so almost on this one. Okay, nothing is falling on the thick line. So let us say I have taken this, and this is 1 by now, another 2 by now, another 3, isn't it? 3 is what? 3 is point, this line is the immediate line. This will be 300, 150, 100 line. So it's exactly 3 squares away. 3 squares is 0.2 into 3 is 0.6. 60 divided by 0.6 is equal to 100. Immediately you can say that the rate is around 100. For example, you see the answer there. Okay, now what is the heart rate in this ECG? Okay, this is the thicker line here. So next thicker line is 300 line, 150, 100, 75, 60, 50, 43, 37. This is what we know. But the QRS complex occurred 1, 2, 3, 4, and 5. That is 4 is 0.8 and 5 is 1, isn't it? So between 0.8 and 1, 0.8 line we know this is 300, this is 150, this is 100, this is 75. Okay, this we know is 60. So the heart rate is somewhere between 75 and 60. Exactly the wave is mid position. Between 75 and 60, mid position will be 67. What will be the answer in this particular case? 67 is the heart rate. As simple as that. So what all I have to do is I should memorize that the first line is 300, second line is 150, third line is 100, fourth line is 75, fifth line is 60, 50, 43 and 37. Suppose if the complex occurred here and the next complex occurred here, let us say, it will be 1, 2, 3, 4, 5, 6 boxes. 6 boxes is, at the rate of 50. So this is the rate of 43 and this is the rate of 37. So this is how you go about. So let us see can you tell me what is the heart rate in this ECG? Take one thing which has fallen on the main line. So it has fallen on the main line. This is 300, 150, 100. Between 150 and 100 is 120. But for example, here you see, look at the RR intervals. Now what you have to do is, first thing when you want to look at the rate is, are the RR intervals or the cardiac cycle is regular? Are the RR intervals constant? So for example, here the RR interval is hardly 2.5 squares. Here the RR interval is more than 3 squares. Here is around 3 squares. Here is again little more than 3. Again, this is also little more than 3 squares. So when the RR interval is shifting like that, we will not be able to say exactly this is the rate. So the fundamental requirement for our rate calculation is RR interval should be constant. For example, see here, are the RR intervals constant or not constant? Exactly. So you see here, what is the distance between them is the same as this one and that one. So in such a case, you can determine the rate. For example, you see the previous ECG. Here also the RR intervals are very constant. So you can expect the rate very correctly. There is not very difficult. But if the RR intervals are not constant, that means there is an arrhythmia. So what we have to say, the answer here is none of the above, as the rhythm is not regular. So look at the RR intervals. You can see with the arrow length now you will be able to really look at the arrow lengths are different. So this arrow is much bigger compared to this arrow, and each one, this is again little smaller. This is midway. This is again larger. So the RR intervals are not constant. You will not be able to determine the rate of the ECG. Now, all of you, I'll show you one ECG. You tell me the rate. Okay, I'll give you the exercise at the end. Let us recapitulate what did we learn in the rate determination. For the rate determination, we have to look first whether the RR intervals are constant or not. Whether the RR intervals are constant or not. And then we have to see the distance between the two QRS complexes. If the second QRS complex occurred on the immediate darker line, and the first one is on the darker line, then it is 300. The next darker line means 150. Next will be 100. Next will be 75. Next will be 60. Next will be 50. Next is 43. Next is 37. 300, 150, 100, 75, 60, 50, 43 and 37. If you remember those numbers, it is child's play to say the rate very easily. Only thing is the RR intervals have to be constant. Now, I wanted to introduce the concept of axis. QRS, mainly the axis can be calculated for any wave. For example, P wave axis, T wave axis, QRS axis, all three are possible. But the dominant contraction and dominant electrical activity is from the left ventricle, from the ventricles. So we require to know the QRS axis of the ventricles. That is the electrical axis of the ventricle. So what is the electrical axis? Electrical axis is the direction of the flow of the current in the heart. The direction of the flow of the current in the heart. Where is it originating? It is originating in the SA node, somewhere on the upper right part. From then it spreads to both the atria, comes to the AV node, slight delay there, the PR interval. enters the AV bundle, then goes through the Purkinje system, activates the ventricle. So the axis is, first of all, it is leftward. Second of all, it is downward. And third, heart is the right atrium and left atrium atria are posterior. So from the posterior to the anterior, apex is anterior. So the current is coming posterior to the anterior. You understand? So the direction of the current is leftward, downward, and anterior. For that reason, we have placed some cameras on the left, some on the downward, L2, L3 AVF. On the left side, we have placed the cameras like, L1 AVL and then V5, V6 on the left side. And we have placed some on the anterior because the current comes forward. That register that we have placed the anterior cameras. Now, let us look at the axis. Now, let us look at all the 6 leads, limb leads we will first look at. This is called the frontal plane. Frontal plane is this plane. And transverse plane is this plane. The chest leads record the transverse plane and this records the frontal plane. The frontal plane, we said that L1 is between right arm and the left arm. What is L1 here? That is the L1 lead. Right arm and the left arm. From the right arm being negative, left arm being positive. Always remember, a wave will be positive if the current is towards the positive lead. A wave will register a positive deflection if the current passes towards that lead. If the current is towards the left-sided leads will register positive deflection. That is why AVL, L1, V5, V6 always have a positive deflection of the QRS. Because they take the positive side is there, AVL positivity is here, V1 positivity here, and this is the horizontal lead. This is the horizontal lead or the L1. Then there is another lead which is taking potential from the AVL, its left arm itself, right arm being the next, all the other 3 limbs being negative. So this is called the unipolar lead and its axis, it is placed, if this is 180 degrees or horizontal, that is a little away towards your this quadrant, upper outer quadrant. So that is the -30. Then we have 2 other leads, L2 and L3. L3 we know negative is on the right arm and the positive is always the foot. We know that for all these things, positivity is the foot. Because we know the current is going down, we want to keep the positivity down to record a positive deflection. So L2 positivity is seen normally because the impulse is downward, and sometimes L3 also will be positive if the heart is vertical. If the heart is placed horizontal, then L3 may not be positive. But L2 is always a positive deflection. L1 is a positive deflection. AVL is a positive deflection. The L2 lead is 60 degrees. Okay. Then AVF is exactly straight and vertical lead perpendicular to the AVL. The foot being positive, any positive deflection here, it is an inferior current will produce here. So L2, L2, AVF, AVL and L1, these will tell the most of the heart will be here. Heart potential travel of the direction of potential difference will be in this part, -30 to +90. This axis is called the normal axis. Supposing it is going beyond towards the right, this is called the right axis, towards the right side. Instead of current going leftward, the current is going rightward. Why? Because of right ventricular hypertrophy, right bundle branch block, whatever may be, several reasons there. Sometimes what will happen, their current may go leftward, but not downward and go this direction. That is called the left axis. So left axis is here, normal axis is here, right axis is here. This is called an extreme axis or indeterminate axis, which normally we don't see. So we are interested whether there is a left axis because we know left ventricular hypertrophy, left bundle branch block, all this, the hypertension, all these produce a left axis. Whereas normal axis is recorded between -30 to +90. Anything this side is right axis when there is a right-sided disease. So you understand this is the horizontal lead. 0 is L1. 180 is in the side. This side is 0. -90 AVL. plus 90 AVR, because AVR, the positivity is here, so the current will be going that direction, and AVR always records a negative deflection because current is away from the from this lead. This lead is this way, so our heart potential difference is going this direction. So AVR is always a negative deflection, and L2 positive deflection 60 degrees, AVF positive deflection 90 degrees. L3 may be positive, may be negative, depending on whether there is a sort of. Okay, so this is L3 and this part is the right axis. When we go a little further, you understand it better. So that is the AVL minus 30. That is the L1 0 horizontal. Both are the left-sided leads, AVL and L1. Now we have got the L2, which is 60 degrees, and the AVF, which is 90 degrees, and the L3, which is 120 degrees. The blue colored ones, all are inferior cameras that they record the inferior electrical activity. Supposing there is a left-sided infarction on the left lateral surface, then it will be shown here. If there is a diaphragmatic infarct or an inferior infarct, it will be shown here. Okay, now you see. This lead is plus 30 on this side here, but actually the lead is going, the placed positivity is placed here, but in the calibration here we say plus 30, 0, plus 30, plus 60, but all the waves that are recorded in the AVR are negative deflections and not positive, because the lead is exploring the positivity from that side. Okay, and then you are left with the right side, that is the right-sided thing. And anything in this zone is the normal axis. This zone is left axis. Anything beyond this is the right axis. Let us look at that. The 6 photography of the six cameras, lead 1 and AVR are the horizontal leads, left-sided leads. Lead 2, AVF and lead 3 are vertical or the inferior cameras. AVR is the right-sided camera, cavitatory lead. V1 to V6, 6 cameras are positioned in the transverse plane. In the previous diagram, we understood the frontal plane. Now we are going to understand the transverse plane. In the lateral leads, V5 and V6 are lateral leads. From the limb leads, we know L1 and AVL are lateral leads. So anything happening in the lateral surface of the heart or left part of the heart will be shown to me in L1, AVL, V5, V6. Inferior leads are L2, AVF and L3. These are the inferior cameras. Septal leads are V1, V2. Anterior leads are V3, V4. And anterolateral means V3, V4, V5, V6, L1, AVL. We say anterolateral infarct, anterior infarct. All these are looking at the lead in which the changes are there, we are telling. So look at the transverse plane. So this is the vertebral column and this is the sternum. And we have placed the V1 on the right side of the sternal border in the fourth space. And this is right sternal border in the fourth space on the left side. And these two exactly heart septum is around this point. V3 and V4 are the anterior surface of the heart. V5 and V6 are on the lateral surface of the heart. Suppose there is dextrocardia, the heart is this way, then recording these leads will be no use. So all the four we have to put on the right side. In such a case, we call as this V1 becomes this side and V2 comes here, V2R, V3R, V4R, V5R, V6R. R means we have placed the lead on the right side. This is very important. One day a patient is brought to me with severe sweating and features of acute infarct. We standardly, he is referred by someone. We did not auscultate him or examine him. Straight took the ECG. ECG looked normal, but the patient is not looking normal. Then my sister told that, doctor, the patient is very bad, but you are saying ECG is normal. I said, put the leads on the right-hand side, on the right side of the chest, and we have placed to the right side, and it was a classical infarct, and patient is a case of dextrocardia. Then we examined the apical impulse on the right side. So this is to impress on you when the infarction features are there clinically and you are able to see normal ECG on the left side, you have to do a right-sided lead. Then they are called V2R, V3R, V4R. just to show that they are recorded on the right side. So 6 cameras are photographing the transverse or the anterior posterior plane. This is called the transverse plane. This is called the frontal or the horizontal plane. The anterior posterior plane, V1 and V2 record the septal events. V3, V4 record the anterior wall events. V5, V6 record the lateral wall events. To record right-sided events, we have to keep V2R to V6R are needed in dextrocardia, and also if there is a right ventricular infarction. This case also I have seen. Not only the left ventricle, right ventricle also. If the RCX is blocked, you may get a diaphragmatic infarction and an RV infarct also. RV infarct changes you can get only while recording the right-sided leads. Okay. Now we have to understand how the impulse travels. Cardiac impulse travels, starts in the SCA node in the right atrium, and there is no specialized conducting system for the atria. It is only the atrial syncytium, cardiac muscle itself conduct them. So these are the capacity, the thickness is very small, and the distance the impulse has to travel is also not very much. And we don't require a very powerful contraction of the atria also, because the AV valves are facing downward and the AV valves are open. By gravity the blood shifts. Only the last little bit part of it requires the atrial contraction. That is why in atrial fibrillation still things are going on even without the atria properly contracting. Since we do not, one thing, the atrial musculature is thin. 2, the surface area is smaller. 3, we don't require a very powerful contraction of the atria for the blood to be driven into the ventricle. For that reason, we don't require a crisp, brisk, forceful contraction of the atria. Nonetheless, they contract through the syncytium, cardiac syncytium itself, and it will take a little time for that to happen. That is why the P wave is taking 0.12 seconds. 0.12 seconds for a thinner muscle, smaller area, it is taking 0.12 seconds. That is the P wave. Then it hits on the AV node. When it comes on the AV node will say, wait a minute, my master, the ventricles are not able to now take the blood because the AV valves are not at, the AV valves have to get open, then only any contraction. So AV valves are open already and the blood is flowing. For the ventricles to contract, the AV valves must be closed, then only the semilunar valves will be open and the blood will go into the outflow tract. So for that reason, there is a slight delay between the closure of the AV valves and the opening of the semilunar valves. And that delay is the PR interval or the delay in the AV node. So from here to here, this is the QRS is starting here. So from here to here, 0.12 seconds for the atrial activation and 0.08 seconds for the delay there. And these two together is the PR interval. So that is PR interval starting from the P wave to the QRS starting. So the PR interval. Any delay here is a conduction delay type 1 block, type 2 block, type 3 block, and AV dissociation. All can be studied by looking at the PR interval and also the subsequent QRS complexes. So once it hits on the AV node and crosses the nodal delay, then there is a beautiful wiring is there. So the current goes faster in the wires than through the cardiac muscle. So this wiring has got a bundle of his which divides into the left bundle and the right bundle. So the left bundle activates the left ventricle and the right bundle activates the right ventricle. The septum is activated from the left to the right. From the left to the right, and we are placing L1 on the left side, so the potential difference is going away. It records a negative deflection, small negative deflection in the L1, and that is called the septal Q wave or the normal physiological Q wave. It is because of septal activation from left to right, impulse going away from the exploring lead. That is why you have a negative small deflection. So what is pathological Q? We will see when we come to that. So after coming here, beautifully through the bundles it goes, and this further divides into, because left ventricle being a thicker mass, there will be an anterior fascicle, there will be a posterior fascicle, and both are simultaneously activated. Not only right ventricle and left ventricle, all the parts of both the ventricles are synchronously contracting. This is called cardiac synchrony. Cardiac dysynchrony means atria are contracting separately, ventricles are contracting separately. There is no synchrony between the right and left side. So in such a case, you may require a cardiac, intracardiac devices we may require. So that is a different thing. But anyway, this Purkinje system and the bundle of His and branches, they quickly conduct. When they quickly conduct, what happens? The muscle is depolarized very quickly. That is why the QRS is only 0.08 seconds. A thinner muscle, lesser surface area, is taking 0.12 seconds. A thicker muscle, greater surface area, is taking 0.08 seconds. This is possible because of the electrical conduction there. Why it is required to contract so crisply? It has to push the blood forward, particularly into the aorta against the gradient. There is a lot of gradient there, and it has to pump to the head and to the toes. That should be, the pressure should be generated. Left ventricle has to contract very powerfully. For example, for the right ventricle, the workload is not that much because it has to pump only into the pulmonary circuit, but that is why the right ventricle is thinner compared to the left ventricle. Okay, so the majority of the QRS is because of the left ventricle, and lead 1 being the exploring lead on the left side, it registers a positive deflection. The duration of this is 0.08. Supposing there is a conduction block in one of these things, this will first get widened. That is called widened QRS complex of more than 3 small squares or 0.12 seconds. So this is how the cardiac impulse activates. Now, let us go a little further and see how this is important. Cardiac impulse originates in the SA node, traverses the atria simultaneously, no special conducting wires, so it takes a little time, that is 0.12 seconds, reaches the AV node, which is the check post, delay, the PR in interval, PR segment. The PR segment is around 0.08, that is the delay there, enters the bundle of His and branches through a specialized conducting wires called Purkinje network, activates both the ventricles, and a quick, crisp QRS is produced. So this is called narrow QRS or normal QRS. If the QRS is wide or bizarre, it suggests that the ventricle is activating on its own, or there is a bundle branch block. First the septum from left to right, then the right ventricle, then the left ventricle, and finally the wave reaches the apex. All of this happens very quickly in a span of 0.08 seconds. Then the ventricles recover for the next impulse. That recovery is the T wave. Now, we have come to the QRS axis. As I told you, anything between -30 to +90, the green colored area is a normal left axis. That means heart's impulse is going down left, going down, and anteriorly from posterior. That is a normal axis. Okay, instead of the impulse going down, let us say it is going up in this direction, then this is left axis. Instead of the impulse going down, all right, but going to the right, in case of right ventricular diseases, then this is a right axis. This one is called the indeterminate axis. So -30 to +90 is usually called as the normal axis. -30 to -90, this is called the left axis, and +90 to +180 is called the right axis, and this part is the indeterminate axis. So the southeast quadrant is left axis, and southwest quadrant is right axis, northwest is indeterminate, northeast is the left axis. So forget about northeast, southeast, understand this diagram. And this lead is the horizontal lead L1, this is the vertical lead AVF, this is the left-sided foot positive lead L2, this is the foot positive lead L3, and AVL of course is always positive on this side. AVR, the positivity is here, and that is the 30 degrees. So this already we have understood. Now, what is the use of knowing the axis of the heart? It tells which is the dominant part of the heart contributing to the electrical activity. By then we can infer what good disease it could be. So that is the left axis, and that is this. So first one is the normal axis. The second arrow is the right axis. The third arrow I am showing is the left axis. That is the indeterminate axis. Normal axis when it is downward and to the left, southeast quadrant, minus 30 to plus 90. Right axis when it is downward and to the right, southwest quadrant, from it, now that is 90 to 180, this side. And the left axis when it is upward and to the left, northeast quadrant, minus 30 to minus 90. Indeterminate, northwest quadrant, the uppermost, this side, which is the minus 90 to plus 180. So just remember this diagram, very easy for that. Then how I place my ECG axis in this particular 4 quadrants. I am interested only this much. I am really not interested with 30 or 60 or 65 or 70 or 33 or 34. Clinically, it is not very important. Is it left axis? Is it right axis? Is it the normal axis, left axis, or right axis? That is the clinical interest. But of course, you can always say I have 33 degrees, another ECG is 66 degrees. Everything is normal. Saying the height of 5.2 versus 5.6, 5.7, everything is normal only. But for comparison purpose, you may require to know the axis. But for prima facie diagnosis, you may not require to know exactly the axis, whether it is left axis or normal axis or left axis or right axis. It suffice to say that. Likewise, the heart rate, is it in the normal range? Is it tachycardia? Is it bradycardia? Is important. Here also the axis can be viewed in this fashion for simplicity. Now, how do I determine the axis? Look at these 4 leads. Only 4 leads. For the axis, don't look at anything else. Don't look at anything else. And underline the word not required to look at anything else. L1 is what lead? Left-sided lead. L2 is inferior lead. AVF also is inferior lead. Normally, our impulse is leftward and downward. So, all of them should register a positive deflection. L1, L2, AVF particularly, these should require a positive deflection. That means it is a normal axis. Why positive deflection? We know the exploring lead, the current is towards the lead, it registers a positive deflection. Our L1 is towards the left, so heart impulse goes to the left, so it registers a positive deflection. Likewise, we also know the impulse, cardiac impulse, not only travels leftward, it travels downward also. That is why the inferior leads, particularly L2 and L3, L2 is 60 degrees, AVF is 90 degrees, L2 and AVF. L1 is 0 degrees, L2 60 degrees, AVF 90 degrees. So the 90 degrees camera and the 60 degrees camera will register a positive deflection, and L1 0 degrees camera will register a positive deflection because the impulse is leftward and this is downward. That is why L2 AVF are positive. So all upright. What did I look at? I looked at L1, L2, LV, AVF, and L3. The 3 inferior cameras and 1 lateral camera I looked at. All are positive deflection. That means I am in the green color quadrant. That means it is towards the left and downward also. Now, in this case, L1 is recording a negative deflection and L3 is recording a positive deflection. Okay, L3 is an inferior lead. It tells me the positive deflection. L3 tells me that the impulse is going down. Okay, that is normal. But instead of it going towards the left side, it is a left-sided lead is recording negative. That means it is not going to the left. It is going away from the left. That means to the right. So such a situation is what is called the right axis deviation. L1 and L3, you look at L1 down, L3 up, the waves meet each other. This is what is called the right meet. Right means the waves L1 on the top and L3 here, they meet one another. Very simple to understand. So right meet. Now, you look at here, L1 is positive. That means the impulse is going leftward. That is normal. So I expect it to go leftward only. It is okay. That's not a problem. But look at L3. L3 is downward. L3 is a camera that is 120 camera. It is recording a negative deflection. That means it is exactly going opposite to the 120 degrees, which is more than minus 30. So maybe minus 40, minus 50, minus 60. So the impulse is leftward, all right, but not, the impulse is leftward, but not downward. Leftward and upward means left axis. The waves L1 and L3 main deflections, they leave each other, left leave. So understand? All upright, no problem, because inferior camera should be positive and left camera should be positive. Our cardiac impulse normally is in the green quadrant, leftward and downward, no problem. Whereas when the impulse is downward, all right, by the L3, but not leftward, but away from the leftward, means towards the rightward, that is an abnormal situation called the right axis, in which case the L1 and L3 meet each other, right meet. Whereas when we have an impulse going leftward and upward, the leftward camera L1 records a positive deflection because it is going leftward, but it is not coming down. So my AVF and the L3 particularly will record a negative deflection because it is going away from the inferior lead L3. So look at L3 and L1. L1 and L3 meet, it is right axis. L1 and L3 leave each other, the waves, it is the left axis. As simple as that. But this will not tell you whether it is 30 degrees or 35 degrees or 63 degrees, because I am not interested. As a clinician, my interest is it left axis? Is it right axis? Is it sort of normal axis? Okay. But you can always plot, and I will show you how to plot and then tell the exact number of the axis also. I can tell you that I will show you on the board. Suffice to know quickly, for a quick view, this is sufficient. So normal, right and left, you have understood. Now, let us see. In the tabular form, I have put. Normal axis means L1 will be positive, AVF will be positive, all the four leads are positive, both are up. Right axis, L1 is negative, AVF is positive, that the waves meet, that is why right meet. Left axis, L1 is positive, AVF or L3 is negative, they leave each other. That is called left leave or left axis. Indeterminate, L1 will be negative, AVF will be positive, and that is not useful because that is a very rare situation. We don't get in, so we don't require to know about that in the prima facie. Now, you tell me what is the axis in this ECG. What leads I have to look at? L1, L2, L3, AVF. AVL and AVR are not my concern. I am only interested to look at L1, L2, L3 and AVF. All the 6 limb leads are given to you, but concentrate on L1, L2, L3 and AVF. And tell me, you can type also your answer. Are all the deflections positive, or anything is negative among the 4 leads which we are interested? Positive or negative? All are positive. Means it is a normal axis. Can you tell me what is the rate of this ECG? We already know how to calculate the rate. So we know this is fallen on the thicker line. This is 300. This is 150. This is 100. This is 75. So this is closer to 75 than 100. So probably around 80 is the heart rate, which is normal. Understand? 300, if it has occurred, the next QRS we would have called 300. If it occurred here, we could have said 150. If it occurred here, we could have said 100. If it occurred here, we have said 75. Here it is 60. Here it is 50. And here it is 43, and this is 37. But it has occurred after the 100 line and before the 75 line. Closer to the 75, heart rate is around 80. What is the axis here? Normal axis. Why? Because the left camera showed a positive thing, L1. And the 3 inferior cameras are showing it is going downward also. Our cardiac axis, normally the impulse, is leftward and downward, which is a normal axis. So this is a normal axis. Now, why QRS voltages are positive and upright in leads 1, 2, 3 AVF, L1 and L2 AVF tell us it is downward, L1, L2, L3 AVF tell us downward, L1 tells it is to the left, downward and left is the normal axis. Now, look at this ECG and tell me what axis it is. We have to look only L1 and AVF for the right and left axis. If the L3 is given, it's okay. L3 also you can look at, or AVF you can look at. Both of them are the same. First of all, what is the rate in the ECG? We know how to calculate the rate. So this has fallen on the darker line. This is 300. This is 150. This is 100. This is 75. So between 100 and 75, closer to 100, maybe 95, 93, 94. It is not a tachycardia. It is less than 100. So it is normal heart rate. Heart rate problem is solved. Now, what is the axis? Here, left camera is recording negative. That means the impulse is going away from the left side. Away from the left side means towards the right side. But the inferior camera is showing a strong positivity. That means it is going downward. Downward and to the right is right axis. Here L1 and AVF or L1 and L1 and L3, the waves are meeting each other. They meet each other. This is what is called the right meet criteria. Okay. Now, note the QRS voltages are positive and upright in leads 2, 3, and AVF, we don't have so many, we have only AVF is there, negative in L1. L2, L3 AVF tell me it is downward. L1 tells me it is not towards the left side, but to the right. Downward and rightward is right axis. Right meet criteria is satisfied. QRS and L1 AVF meet right axis deviation. Now, look at this ECG. First of all, tell me the rate. What is the rate of the heart? Heart rate. So let's say this has fallen on the thicker line. This is 300 line, 150 line, 100 line, 75 line, 60 line, 50 line. It is not below 60, but it is 60 to 63 like that. 300, 150, 100, 75, 60. Heart rate is around 60. 63, 64 like that. You can look at another lead also to see the RR interval consistency. 300, 150, 100, 75, a little more than 60. So it's not bradycardia, neither it is tachycardia, it is normal heart rate. Now, what is the axis? We are given all the 6 limb leads. L1, it is a positive deflection, means the impulse is going leftward. L3, it is a negative deflection, isn't it? That means impulse is not going downward, instead it is going upward. Upward and leftward is left axis. So the L1 R wave and L3 S wave, the waves are divergent, discordant, not meeting each other. Instead, they are leaving each other. So this is a case of left axis deviation. What is the axis here? Each ECG you see, immediately question what is the rate. Then automatically get used to know how to pin the rate. And what is the axis? Left axis. Why left axis? QRS voltages are positive and upright in leads 1 and AVL, negative in the inferior leads. L1 and AVL tell me it is leftward. L2, L3 AVF tell me it is not downward. Instead, it is upward. Upward and left is left axis, left leave criterion. QRS and L1 and AVF leave each other, left axis deviation. So this is where we will stop here. Yes, sir. Good. Now, this site has got a home screen and then its introduction, outline, image index, test your knowledge. All the areas are there. I will give you the web address. So let us outline. Let me click. What he is showing is standard 12-lead ECG, method of interpretation, characteristics of normal, ECG measurement abnormalities, and then rhythm abnormalities, conduction defects. This is the atrial enlargement, ventricular hypertrophy. Like that it goes. We have done the standard 12-lead and also the characteristics of normal ECG and also the axis also, conduction abnormalities and the axis measurements are there. So you can click any one of them and look at that. And let us say this is the thing. So you could have seen this. This is a bigger image which we have seen. The image is taken from this website. You have already seen the image on my presentation. This is what. And then the waves and intervals, ECG waves and ECG intervals it tells. So it gives you what is P wave, what is the different waves. So this is how we will probably end this session here, and we will meet next Tuesday with more information about ventricular and atrial hypertrophies. And before that, we will do a couple of exercises on that day, and then we move on to that. So with this, I am stopping.